to continue the theme about behavioural change and lifestyle and things like that, we have our next speaker. She is one of 9 children. She hails from New Zealand, and she has worked in cabin crew on aircraft. She's been a talkback host. She is an author, and in 1997 was the recipient of the New Zealand NO National Service Award for services to nursing. She's been leading the behavioural health training program for the past 16 years and is currently the Honorary Clinical Lecturer in the School of Nursing at the University of Auckland and has recently completed her Masters in Nursing. She's a current board member of the New Zealand Health Promotion Agency and a member of the New Zealand Lottery Health Research Committee. Interestingly, at the time of her marriage, she was married on a small island known as the Chatham Islands. And what struck her about that event was the fact that there was only one shop. And when there is only one shop at which to purchase wedding gifts, the options are fairly limited for the bride and groom. So every islander on their wedding day gave her towels, and 40 years later, 40 years later, she's still up to using those same set of towels. So there's nothing wrong with a bit of persistence and thoughtfulness from the guests, knowing we all need towels. I thought it was a stroke of genius. Well done. She used to have full eyebrows, interestingly enough. It wasn't something I'm used to receiving information on from a guest speaker. But whilst she was working for a New Zealand airline, they introduced the policy that bushy eyebrows were out. And so plucking was in, and she misses those eyebrows terribly. Which might suggest she has an adoration for Tom Selleck. Big moustache, bushy eyebrows, I think we get the idea. She's met Cliff Richard, which would have been a remarkable incident, a remarkable moment in her life. And she's even had dinner with the Rolling Stones. She just didn't have a clue who they were at the time. She's bungee jumped and thought she'd do that as a great thing for her 50th birthday. And she's a penaholic by admission. So just check your tables, count the pens, count the biros, because she can't resist them. And she is often referred to as a counsellor amongst her team, because as people's lives fall apart, they tend to go to her for counselling. She's been involved in bank robberies as a victim, not as the robber. And her great-great-grandfather won the Victoria Cross. So what I'm going to ask you to do is everyone be upstanding if you could. Just bear with me, just be upstanding. And what I'd like you to do is, as our next guest speaker is from New Zealand, I'd like you to pose a fierce warrior stance. I'm going to ask you to poke your tongue out and give our next guest speaker, keynote speaker, a harker of a welcome as we bring to the stage Barbara Docherty!
Phew. Thank you, Stuart. I didn't realise I'd given him quite that much information, but I remember my daughter sitting with me when I was writing it, and she said, "You've got to do the eyebrows one." So, anyway, that's the truth. That's what happened. Tēnā koutou, tēnā koutou, tēnā koutou katoa. That's greetings from New Zealand in our te reo Māori language. And I'd also like to acknowledge the Australian Indigenous people, and in particular, the Gadigal land on which I'm standing. And hello to my New Zealand colleagues. Are they actually here? Oh, yes, they're here. Hi, hi. And also to all the new primary healthcare nurses. I think it's brilliant that you're here, and I hope you're getting a lot from the conference. I'd also like to now take the opportunity to thank this organising committee and APNA, not the APNA, APNA. It's been the most brilliant conference. It's the best primary healthcare conference I've ever attended. And I mean the organisation and being a guest speaker and so forth, you know. all the little detail stuff that goes into being a speaker and having to get all that information, and there was just not a moment when it wasn't there, and so I think you guys have been amazing. So thank you for that. Thank you for that. Right, on to behaviour change, and why do we actually bother? Well, we bother because morbidity and mortality are driven largely by chronic conditions and behavioural factors. We all know that. Throughout the world, too many people die prematurely. We know that's usually from chronic conditions, and we know it's usually due to unhealthy behavioural practices. More than 2 out of 3 premature adult deaths is due to behaviour initiated in teens. That's where it all stems from. In primary health care, we continue to concentrate on just a few risky behaviours, though, and ignoring many of the other potentially harmful behaviours and the interactions all these have with mild to moderate mental health risks. I'm going to go into that a little bit more soon, but for example, 3 cannabis joints a day is the same as having 20 cigarettes. It does the same damage to our lungs, but you never talk about cannabis in primary health care or general practice very much. Gambling takes a huge hidden toll, increasingly for young people, and young people admitted to hospital for diabetes have an increased risk of death in the following 3 years from suicide. But we hardly ever consider that when we're talking to our young patients around diabetes. Weight loss, bulimia, anorexia nervosa still hides unhappily and quietly behind big sister obesity, even though it is causing untold damage to many young men and women. It is only recently that the World Health Organization is actually saying that childhood obesity should be the focus rather than our constant attention to adult obesity. A simple equation. If we start tackling all this when people are young, we could save thousands of lives, to say nothing of the dollars. This is called prevention, and you'll be hearing more about the significance of this as I go along. In fact, I think I would rather be a preventologist if I was actually reborn, because there is no such thing, but I think we ignore it so much. I'm just going to take you back a step to the beginning of my long journey on researching and redeveloping behaviour change approaches. It began with 23 years of practice nursing, where I gave advice and instruction on thousands of occasions to try and get people to change their unhealthy behaviours. Sound familiar? Most of the time I knew I wasn't getting anywhere, but I never bothered to ask myself why. And until I became project manager of the primary health care training facilitator in the TADS program in 1996. Tobacco, alcohol and other drugs was what TADS stood for, and it was in the Auckland University's Department of General Practice and Primary Health Care. We were asked to start to form a brief interventions training program, which is what Gary referred to earlier. The World Health Organization wanted the Auckland University to set this up, and so we were charged with having to train general practitioners, primary health care nurses, practice nurses, anybody who was actually working in the field of primary health care. So we had to develop the program, and it included our Indigenous people, Maori, and also Pacifican youth. Now, this is quite significant in terms of the background of and the future of behavioural change interventions in New Zealand, because this was the foundation of brief interventions in New Zealand. It was the foundation of what we were supposed to be doing to help people in primary health care to no longer smoke or drink alcohol or take other drugs. The only thing is we hardly ever talked about other drugs, we only talked about tobacco smoking. The problem was that TADS had a funding commitment to holistic wellness and prevention. That was in our brief. It was clear as it was in our brief. It was black and white. And this, of course, is the basis of primary health care. But the brief interventions training that we were to develop for this general practice setting was based on international literature around alcohol and brief interventions, which had shown some success in specialised addiction treatment centres. Motivational interviewing was the basis, and out of that came brief intervention. So you'll be seeing and hearing a little bit more of this from me, and why I know now that brief interventions do not work in primary health care. Even though we're kind of going back to that, we are in New Zealand, we're going back to an ABC, and that's again giving advice and instruction, and that's how motivational interviewing and brief interventions work. Because they're based on this, which is more of a treatment, not a preventative model, and no evidence to support translating this into general practice and primary health care, we've had very little success with it. Eventually, the more people we trained, in TADS, the more doubts began to emerge for me as a nurse that this type of intervention was totally unsuitable. So with no other nursing support in this Department of General Practice, several times in fact I wavered in the put-downs and how I was being treated as a nurse, trying to even suggest that changing this was because it looked like patients didn't like what we were doing. And it wasn't about the training, it was about patients and practitioners beginning to feel there was something not working here. At times I wavered and I actually felt like I was spitting at warships. And I just decided that I'd start this exploration as to why this wasn't working. So we had, of course, started with money funded by the government and had to try and make these brief interventions fit. When we embarked on the redevelopment, we decided that we would start with the patient instead. So over 5 years, we slowly worked with 2,500 people and communities, and adults and youth were involved in this. Maori Pacific youth, I was working at that time in the lowest socioeconomic area in New Zealand, so I had great access to people in that particular area. We also went, of course, into the high decile 1 to 10 schools, which is the lowest to the highest economic areas. We tried and tested, we rectified our mistakes, all the time trialling this in the training workshops. I was able to take a lot of it back into the general practice that I was still working in, and we just kept getting these stories from the patients who themselves in the end became the researchers. They gave us everything. They gave us everything we developed. They gave us all the stories, and it took 5 years. Everything that they said wasn't working for them was what keeps coming up today. All the time. 2 New Zealand District Health Boards, our Ministry of Education and our Ministry of Health Public Health Directorate came on side and were instrumental in assisting us to get this underway. So what actually happened was really interesting, because when we went out to all of these patients and we were going backwards towards, we had lots and lots of focus groups. We had hundreds of them, and we made a lot of mistakes along the way. We went back to them again and said, we've tried this and it hasn't worked. What are we doing wrong? Everything was led by the patients from the very, very beginning. And what we found very, very clearly over this time, no question about it, these are the top barriers as to why people choose not to change their behaviour. And out of it came advice, information and health messages. We just keep dishing them out all the time. They're not helpful. People don't take them in. Health professionals' attitudes, behaviour and language was almost top of the tree. The way we speak to people, the way we preach, the way we talk to them, the way we drive the process. And that being ready doesn't mean that they're able and willing to do anything about change. So people will say, I really want to lose weight, I really want to stop smoking. It does not mean to say that they're actually ready to be able to do this, because they have to be willing, which means it has to come from another part of their inner being, and they also have to know that they're able to do it. And this absolutely has to be explored before we can move any way and any step forward around behaviour change. Trust me, I know this to be a fact, because once you've determined that, then the person knows where their next step is to be. Without it, we're wasting our time. Screening tools, they hated. It just reduces trust to such a degree that they said as soon as we get them to fill out a screening tool, we're on top of them to decide what has to happen next. We then continue to make the decisions around where they should be going for changing that unhealthy behaviour. For practitioners, it was very clear. They lacked confidence, GPs and nurses alike. They didn't know how to start the conversation. They needed an entry into that conversation. Where did they start it and how did they start it? Their frustrations around difficult patients, why didn't they listen to their advice? Why was it wasting so much time? We spend hours talking to them and they take no notice. Interestingly, all our TADS pre-workshop assessments, where we get a lot of information about where the participants are coming from and where they're thinking with their knowledge and their confidence, etc., 9 out of 10 times these barriers still remain the biggest for them about trying to access and have conversations around unhealthy behaviour. On top of this, missing in action was there were no international screening tools at all specific to lifestyle behaviour and mental health risks. Every single tool that you're filling out includes medical history. The patients get confused about their health around medicine and then having to make decisions around changing unhealthy behaviour. The more that we include these two in our medical assessments and lifestyle behaviour all mixed up together, the more confused the patients become. So they wanted that out of their lives. On top of that, we have many, many missed opportunities in general practice to have those conversations, and there's little or no attention to prevention. The core of nursing and primary health care is prevention. They also needed this non-threatening entry into a person's world of behavioural practices. How do you start the conversation? And how do you have a language of engagement, which is the generic form of communication which you take right through from the moment you first introduce that tool? So we had a lot of work to do, and no wonder it took us such a long, long time. So we had to change, and we changed as we could see the patients changing and telling us that we were getting onto the right track. This is why it became so obvious why brief interventions didn't work. We called it brief opportunistic interactions. The intervention means that we're actually intervening, but the interaction means you're having a conversation, you're sharing that conversation with that person. So the brief interventions are based on addictions and treatment. It comes from specialised settings around alcohol. That's where brief intervention started. So if you're giving advice and treatment from that perspective, you're pushing forward your preferred course of action. It's as simple as that. So what we decided to do was base this on early prevention. Now, early prevention is a name that I coined when I was doing my master's, but I'll be explaining that in a minute as to what early prevention looks like as opposed to prevention, where we talk about other things mostly around public health policy. It is practitioner-driven if it's a brief intervention. It's our preferred course of action. It's what we're saying from the beginning is what we're hoping they will do. When you're talking about a BOI, it's driven by the patient, it's person-focused. Brief interventions are a short-term aim. A lot of the studies that have been done on smoking, for example, and Gary, you mentioned one, they're not long-term. They usually do them up to 12 months. And up to that time, a lot of people can change behaviour for a while. But after that time, that's when things often go downhill. So it needs to be long-term sustainable change. So the foundation has to be set from the very beginning. Brief interventions have targeted behaviours and only those at risk. So in other words, we decide that some behaviours are more important than others to try and help people to change, and those at risk, these people are at risk, there's certain criteria of people. With the BOI, all ages, ethnicities and multi-behaviours, including mental health risks, are included because this is primary health care. And brief interventions is time inefficient. We repeat everything. The brief interventions are often not brief, they're often a lot longer. In the BOI, it's time effective because nurses do it in the context of their work. If any of you are coming to the workshop later on, I'll be able to explain that a lot more. There's just too much to cover in this presentation. But the reality is that you are actually having an informal conversation in the context of something else they've already arrived for. So you're not ringing them up and saying, we're having an appointment with you about your smoking today. It's all opportunistic, so it makes your life a lot easier and it's very, very time efficient. In brief interventions, you have frequent consultations and duplication, and in brief opportunistic interactions, there's no duplication because the person's driving the process and you only need to have that piece of the conversation once. Right, now this is the key. When we needed to find something that was a resource for that early, that first place to enter that person's world of personal behavioural practices, we had to produce something, and so we produced what we call the TADS PACT, and that stands for a Personal Assessment Choice Tool. It was named by young people because they liked the name, and we thought it was pretty good too. It says what it is, really. It looks like this. No, it doesn't. It looks like this. It's just back and sides. Simple. If anyone wants to have a look at it later on, they can. I've got one of the adult and one of the youth sitting here, so you're welcome to have it. If anyone dares to take it away, I've got a GPS attached to it, so you'll be caught. We are, whether we like it or not, we're the sum total of all these parts. This is who we are. For better or for worse, this is who we are. Our patients are always a mix of this stuff in some form, but it doesn't mean they have problems. It does not mean that just because someone ticks a box and says something that they have a problem. So we have to get that really right out of our heads. When we look at all these things that are going on in our lives and then we only concentrate on tobacco, smoking, physical activity and weight, we're missing. We're not only missing all these other things that are sitting there quietly in the underbelly of our thinking. But we also miss the point, that red piece in the middle, which is the starting point for that person. Because our diabetes patients, for example, are often, they have mild depression. We don't always pick that up. They just don't like having the disease. They may be using the poker machines. They may be drinking more alcohol while they're doing that, avoiding sex. A lot of these are invisible, early or existing behavioural problems which we do not pick up. And while we concentrate on the important blood sugars, we can miss that this life is on a path to slowly spiralling out of control, and they cannot self-manage because we are looking all the time at the sort of things that we think matter, which are those things, and who are the risky people. Everybody is at risk. Every person in this room is potentially at risk of some early potential harmful behaviour emerging. We don't ask the questions in general practice because we miss 80% of those opportunities because we can't see anything. That was one of the major pieces of our research, that we are missing so much. I guess buried in all of this, when I'm looking at this and showing you what this getting to the sources, that everyone has a special story that we need to get to, the story that has a priority behaviour that they don't want in their life anymore, and that's the starting point, not the one that we want it to be. This is the fundamental foundation of any behaviour change choices, and patients have clearly identified that they don't want health professionals to make this choice on their behalf. So, we've got to get lower than that. Sadly, the often lengthy conversations nurses have because they're funded to have them. We do believe that patients share their innermost secrets with us, but in actual fact they don't. They only share what they want to share, and that's that usually 5% piece. We do not get below that surface. We like to think they do, but they don't. The PACT goes deeper. It was developed not as a screening tool because patients didn't want that, but it's a questionnaire which gives individuals an opportunity to get a snapshot view in their mind of all their personal behavioural practices and mental health risks. When you have a look at the PACT, you'll see it doesn't say how many cigarettes do you have a day, how many do you smoke, how many do you drink. It doesn't say that. It gives people a picture. For example, do you ever smoke tobacco? Yes or no? Have you ever felt the need to cut down or stop smoking tobacco? Now, this is to give them a picture. It doesn't matter whether or not it's happening now or whether it happened in the past. When it's combined with all the other questions on there, they get a really clear snapshot view of who I am right now. Now, the difference with this is that all these responses are kept confidential to the patient. It is never seen by the practitioners. And that starts the trust that they asked for. They wanted something that meant we weren't going to read those answers and then pounce on top of them and make a decision as to where they should start to make that change and how they should do it. And this has become the pivot. There is nothing else in the world that's doing this. And it's very, very difficult for health professionals to move that feeling of not looking at something and not spying over their shoulder and having to do their job and fix something. But for patients it works, and for practitioners it works, because it's what happens next after that, that, as I said, anyone who's coming to the workshop will get a better, clearer picture of what happens next. But the main thing is that this is the legitimate entry point, and then the shorter interactions which follow become that ongoing brief opportunistic interaction process, which allows them to identify the priority starting point for them from this, and then taking them through a very short, sharp 5 questions of are they ready and willing and able to start thinking about making some changes around that behaviour or mental health risk that they have chosen to start with. That's the key. Without that, you can ask every question under the sun, but if you have not got that foundation, you're on a hiding to nothing, and so is the patient. So that was the pivotal part of our research. And even though patients do exactly as we say sometimes, and many of you will be really content with that, some nurses, like all health professionals, find it easier to stay with the status quo. For others, it may be a real need to move away from current approaches, but the difficulty for all of us is not so much the notion of embracing new ideas as in escaping from old ones. And make no mistake, this requires our primary health care role as nurses to not be about pushing our own personal agenda, which is what we're funded for, because we're funding the at-risky behaviours and specifics, and only 3 out of 23 behaviours and so forth. If you start thinking about it as your role being to work alongside patients to not to push our agenda, but to facilitate in removing the obstacles to change. And when you think about it like that, and you realise that we are one of the biggest obstacles because of our attitudes and behaviour, because we don't know how to have the conversation, then I just say that makes life a lot easier, and it actually helps us to stop feeling that we have to. For 5 minutes, is it? No? All right? Did somebody else do that? You had enough? Okay. Sorry, there's a bit more to go yet. And for your sins, this is for you now, right? Right. This is what primary healthcare nurses in a survey we did told us. And, we won't go into it because we're probably not going to have time, but here is this nurse saying how much she loves being a practice nurse. So, helping with good health outcomes. For example, I was in the shopping centre and patients were having coffee and donuts. Both were on a high-carb, sugar-free diet and trying to get blood sugar levels down. They told me to look the other way and covered up their donuts with a serviette. We all had a good laugh together, but I will definitely talk to them when they next come into the surgery. Now, that kind of speaks for itself, and I was that nurse a number of years ago. I was. All right, so why primary healthcare nurses in this kind of change? Well, look, it's called primary healthcare nursing. It's wellness, holistic, and it's prevention. I could list endless reasons as to why this approach has changed my practice in ways that I can't even tell you, because I can tell you how badly I used to do this sort of interactive stuff, and I thought I was doing a great job. But seriously, I think without having to look at yourself closely and say, yes, I was just like that, there was no way I could change. But the real gift that you receive is the change in your patient relationships, and I'm telling you, they change visibly in front of you when you start changing your conversation. It's almost unbelievable when it happens. The informality of this process is not conversational, it's not counselling, it's more a conversation. It's so informal that it's easier to do. But apart from GPs and practice nurses in our developmental research, we also utilised school nurses and public health nurses, and they were key in our youth validation pilots. And here's a little bit of the work we did with them. And this is quite key to what happened. Now, if you can get this graph. In the purple, you'll see that's the actual behaviours that they identified from the PACT tool, right? This is just one group of about 6 we did, but this is the one we were validating the tool for. Now that's the behaviours. We had to find out what behaviours they were ticking in order to carry on for our research, okay? We didn't identify them, we didn't know who was doing it. But you can see on that graph that there's 2 blue areas, and those 2 blue areas are what gave us, everything else is like a negative response, and these were a positive response, because the question on that, do you enjoy regular exercise, was the question. Do you ever enjoy any form of regular exercise? That's the question they wanted in there, that's the question we put there. So that's like a positive response, that's why it's so high. So they all said they enjoy regular exercise. The other one was about sexual activity. And it says, if you engage in any sexual activity, does this make you feel okay about yourself? And remember, because nobody's seeing these answers, you're not going to have a question, are you sexually active? This is for them to get a picture. So that, you can see by that response on there, that a number of them said they did feel okay about themselves. Okay? So that's the questions that they responded to. When we gave it to the health professionals to say, okay, you've got all of this information here now, you can see what they've actually ticked. What would you do now if you had that information, if you had actually had access to that PACT tool, which you know they don't? If you did, what would you do? What would you go for? Now, I think you probably know the answer. They decided that they would work with those young people on the issues that they felt were more important than anything else, right? And you can probably see for yourself where they probably went to. The ones they weren't comfortable with, they didn't touch, like gambling. They didn't touch that. But when we took it back to the young people using the PACT and said, what would you choose as your first choice to do something about changing? This is what they revealed. So do you see what I'm saying? We'd go for the jugular on what we saw as the most important parts on that graph. Look at the gambling now. 23 of them identified gambling. More than half of them wanted to do something about changing it. That's a high statistic. But this has changed completely the way that we were doing any interventions. This was the key, because if we keep saying that we decide the starting point of change and the behaviour, we are going nowhere. When you're given a chance to decide that for yourself, that's where the starting point is. And the same thing happened. This is the same. This is nursing students and medical students. The blue line is the one that they filled out on the tool as what they are doing now, right? The yellow is saying what they would like to choose to start changing. See that? So not many of them wanted to do anything about the alcohol. Not many of them wanted to do about tobacco. Mental health risks came up all the time. So we're basically doing everything back to front in a nutshell. How much time have I got? Oh, good, thanks. This is New Zealand style self-management. There's a few things that have changed on that graph a bit, but the point I'm making here is that this is the same patient, not really Joe, different funding for different things, but all those conversations are duplicated, right? So the diabetes review, the care pluses, chronic condition, people over the age of 65. So everything's kind of, in that same place. ABC, smoking intervention, CVD risk assessment. As I said, we've changed a little bit of this in New Zealand, but it's still there in the same place doing the same thing, because we're having the same conversations with the same patient and they're getting really, really, really kind of annoyed about it. A little bit of behavioural change goes in there, but it's all mixed up with the medical clinical stuff. And that's where the problem is. They're thinking, oh yes, I'll tell you what I think you need to know. So that's the problem we have when we try and put all the medical clinical work stuck in with an occasional behavioural change question. It's just going to absolutely put people off and they turn away from it. So here's poor old Joe being asked the same questions over and over and over again. Because see, what's happening here is that we should be looking more at prevention, not just trying to get all this medical clinical work, tick the boxes, get on with it, and then throw in a few questions about behaviour change, because I just want to talk about prevention for a minute. This is core primary health nursing business, and we've lost the art. We've lost the art. For those who believe we are already focused on prevention, let me challenge you on that. Watch continuing education sessions with the title of prevention and check out the empty seats. We tried prevention implementation following New Zealand's groundbreaking document in the primary healthcare strategy. It's never taken off because, and this is what's happening worldwide, prevention is often called preventative medicine. There you go, back to prevention, primary healthcare, and any kind of behavioural change from that being caught up in medicine. It's mostly seen as important public health measures, which indeed they are, immunisation, breast screening, that kind of thing. But it's usually linked to disease models of prevention. Read the World Health Organisation definition sometime and you'll see what I mean. In my recent Masters, I opined that the most significant piece of the prevention and behavioural change conundrum, which has never been addressed, is what I spoke of earlier. The embryonic and potentially unhealthy personal behavioural practices not identified because they're in the absence of visible symptoms. I call this early prevention. The invisible but essential playmaker that should be essential in all preventative strategies, public health policy and behavioural change approaches, and funding to support that. And this is what the PACT does, because this is what people told us they wanted, and that is prevention. It's worth remembering that after 50 years of education, regulation and medical intervention, which has proved that tobacco smoking is the single largest public health success of the last century, yet it has still not produced one specific type of successful behaviour change approach. Think about that. We're going back again and we're changing it and we're going right back to the beginning. So that's what I believe we should have, and that's what the PACT tool and the BOI actually does. So I've mentioned person-focused. Now, patient-centred you probably all have embraced. You know what that's about. I don't want to confuse it with that because the latter is a very essential type of shared decision making. It's often called health literacy, or health literacy is attached to that. It helps guide the clinical decisions if it's patient-centred, and it's very important. But this is still driven by the practitioner with an invite from the patient to be a part of it, but it's not driven by the patient. Person-focused is not about the clinical. It's more about the deeper personal insight as to why behaviours might have led to the disease or condition. This is facilitated by the practitioner, but it's led by the patient. One health commentator suggested that patient-centred care illuminates the patient rather than the person, both of which are important, but you've got to start at the beginning. And if the patient starts to see that mental health risk or that behaviour that they're now incorporating into their life to a greater or less degree, they can then see the link to why their disease or that self-management of that is or isn't working. Because we've got to start at that point. It's got to come directly from them. And here's a few examples. Practitioner driven. Are you still going to the gym? If it's BOI, which is person focused, it's what do you enjoy most about going to the gym? Because if you say, are you still going to the gym? Yes. And you get on with your life and they get on with theirs. When you say, what do you enjoy most about going to the gym? A person has to suddenly stop and think. And 9 times out of 10, you'll hear them say, I don't go. So by changing the language around, you're going to get the real order, you're going to get the truth of all of this. I'm glad to hear you're not drinking so much now. Instead of saying, what is the main benefit you're noticing by not drinking so much? It's really important that you take your medication if you don't want another heart attack. But if you say, what's the one thing you dislike most about taking pills, they start to tell you where this is really coming from. So the language is absolutely vital. How much weight have you lost? What's the thing you've noticed most about eating differently? You're not talking about weight. You're not putting them on the scales. What's the one thing that you've noticed about eating differently? And you will get a completely different response. And you'll get a true response. How many cigarettes do you smoke each day? What do you like about it and what's not so great? So you're not throwing in any judgment whatsoever. Just very briefly, I was involved in a diabetes tracking study a couple of years ago, and we tracked a large number of patients who had been newly diagnosed with diabetes, and we tracked them with audio and video for 7 months. And we went back and we watched these videos. It was really interesting because what happened was they saw GPs, they saw practice nurses, they saw a number of different people. A number of things happened which was about the language of engagement. They knew their diabetes, amazing stuff around diabetes, but they did not know how to talk to that patient. There were missed opportunities when people mentioned things. They had to stick to this sort of like algorithmic questioning around the diabetes. They kept talking about diabetes. It's supposed to be 98% lifestyle behaviour change and 2% diabetes. Instead, it was 2% lifestyle behaviour change and 98% diabetes over and over and over and over again. It was actually quite disheartening because it looked like going right back to the beginning of our TADS work in 1996 where we weren't getting it right. So what we did was, following the study, I randomly gathered 600 minutes of these interactions. Now you'll see here that we've got GPs, 15-minute consults, practice nurses often up to half an hour, diabetes nurse specialists had an hour, dietitians had an hour, the podiatrists had about half an hour. Now, where the most damage was being done was where there were the longer conversations. So being funded to have a lengthy conversation does not mean that that's the best thing, the best use of or quality of that time. So what I did, I put it all together, just allocated just randomly 600 minutes of this, and I was able to put it down into 15 minutes of a brief opportunistic interaction. I was able to take away that duplication, just change the language, and I did in 15 minutes what we had done in 600 minutes of this work. And that's worth thinking about because it was all about the duplication, people not knowing what the health professional had done before them. It went on and on and on. It was really quite sad. So one more little example of reframing the conversation, how you can change what you're doing. This came directly from our study. Exercise. Patient said, I'm doing my exercise. And the practitioner said, great, how many times are you going to the gym each day now? or each week. And I mean, patients like their practitioners. It's not about not liking them, it's just about not liking the conversation. So the practitioner says, great, how many times are you going to the gym? The presumption is that the patient is actually going to the gym, and if not, then they should be. So this kind of indicates a judgment call. That's how it comes across to the patient. But if you were using BOI language, you'd say, tell me what you enjoy most about going to the gym, because the emphasis is not on going to the gym. It allows the person to offer a more honest response. So they're not thinking about, should I be going to the gym? So it changes their thinking. And there's lots of other examples. Alcohol. I'm not drinking so much now. The practitioner, great. Now how about getting something done about that weight? The presumption is that the good advice is succeeding, so the practitioner moves on to the next instruction. If you instead said, what's the main benefit you're noticing by not drinking so much, that patient then focuses on the main benefit. And if there isn't a main benefit, out comes the real thing. I'm actually still drinking, which is exactly what happened in this. So they're just some examples. So less is more, and if you only had to ask 2 questions, and you didn't have any training, any TADS training or any training at all, start from the beginning. If you're looking at a diabetes patient, for example, tell me what you already know about diabetes. So you're pulling all of that in together in one question. What worries you most about having diabetes? Because the one thing you can be sure of is that they don't want to keep talking about it, they don't want you to keep talking about it, and the other thing is they're very, very afraid. Fear is one of the biggest factors when it comes to behaviour change and having the conversation. So if you do nothing else, remember, less is more. The more you talk, the more the patients are going to dislike you for it. I'm finishing now. Can I just show this? And then one more thing. This has become my metaphor for behaviour change. This was the Christchurch earthquake, and I was working way over in the far distance in the northeast part of Christchurch. I actually wasn't then, I was in Auckland then, but I had been working over there. That's where all my patients ended up with no houses and still haven't, a lot of them. This front part was the CBD. That was the central business district of Christchurch. Now what they did was, they saw all these buildings that had come down, they saw all that, so that's where all the work's been done. They visibly could see a manifestation of all this destruction, so all the work's being done there. Over on that very poor part of Christchurch, they're still being left alone. There's still a lot of work that patients, every time I go back there, those patients are still suffering. So what we don't want to see, we don't do anything about. That's what lifestyle behaviour change is about. What we can see, we pour all that money into, go over and over and over, keep doing what we think is best because we can see it and we think it's more important. That's not what patients think. So just in summary, these are your take-home points. If we learn how to change our communication attitudes and behaviour towards our patients, they will start to connect with us. That less is more. It's not how much we say, but rather how we speak to our patients. Advice and instruction to change are unworkable methods and have run their course in primary health care. Electronic communication will never replace the face and soul of someone that you can see, because changing our language is crucial to the way we presently have our interactions. Combining early prevention, which is primary healthcare nursing, with medicine and treatment, which is doctors, can be a positive, potent and powerful mix in health delivery. But the competing principles and priorities of the voice of medicine and the nursing model of our patients' life world are causing barriers, resulting in the global, systematic and political neglect of real-world prevention strategies. This is not about competing claims or commercial incentives, but rather how all aspects of behaviour change need to be a continuum of care with all players involved. Behavioural health based on prevention is probably viewed as a soft science. It's not sexy. In the eyes of the public, it has legitimacy. Primary healthcare nurses are absolutely core to this implementation. Thank you for listening.